Hello and welcome to the poster session. My name is Host-Mehwish Aabid. I will be the host for this session for the next hour. With me is Dr. Abdullah Gujjar, who is the chair of this session, and our respected judges, Dr. Tufail, Dr. Abid, Dr. Tabinda Dugal, and Dr. Waqas Isthiaq. In this session, there will be 9 poster presentations with 5-minute time allocation to each. In which the 3 minutes is for presentation and the rest of the 2 minutes is for question answer session by judges. Please make sure that you finish your presentation within the 3 minutes time. Otherwise, we'll have to stop you even if you have not finished your presentation. This is to make sure that you have enough time for your question answer session, and also everyone gets a fair chance for their poster presentation. All of the 9 presentations will be assessed by our respected judges, and the top 3 best posters will be given a cash prize. The housekeeping rules are all poster presenters must stay muted, and please unmute yourself when it is your turn to present your poster, and we will be sharing your slides on your behalf. Making a start, our first presenter for today is Dr. Saleem. So if you would like to introduce yourself, over to you.
Thank you to ChemCarnet for giving us this opportunity to present our work. Today I'm going to present my quality improvement project of monitoring of airway device pressures in adults and pediatric patients undergoing surgical procedures. So you routinely employ cuffed endotracheal tubes and laryngeal mask airways for the management of airway, and they help us for effective ventilation and prevent the risk of aspiration in patients undergoing surgical procedures. But with the cuff inflation, there are certain limits, and if they are inflated beyond limits, then they lead to an array of complications. The complications may be very simple, ranging from cough, sore throat, dysphonia, to many sinister ones like tracheoesophageal fistula or recurrent laryngeal nerve damage as well, but they are relatively rare. So in our quality improvement project, we actually aimed to assess the impact of education on airway device cuff pressure monitoring. So we did a prospective audit study, which involved 139 airway devices. Out of these, we had 88 endotracheal tubes, which were cuffed, and 51 laryngeal mask airways. We found that 43% of the endotracheal tubes were inflated beyond limits of 20 to 30 millimeters of mercury pressure. And out on the laryngeal mask airways, the numbers were 84%, exceeding the limit of 60 millimeters of mercury. So this prompted us to conduct an array of educational sessions, and these educational sessions were interspersed over the period of 2 months and involved both the anesthetists and the anesthesia technicians, which are involved in helping us through the conduct of anesthesia. After doing this educational intervention, we actually went on to close the loop of the audit, and we did a snapshot audit including 34 airway devices. Out of these, 27 were endotracheal tubes and 7 were the laryngeal mask airways. Our compliance with the pressure limitations set by the Critical Care Society were met in the endotracheal tubes mostly, but 37% still exceeded beyond the limit, while there was a dramatic improvement in the cuff inflation limits used in laryngeal mask airways, in which only 14% of the devices were not following the recommended pressure guidelines. So we can say that our quality improvement project actually positively resulted in improvement of our clinical practices, and the cuff pressure within the recommended range improved in endotracheal tubes from 57 to 63%, and in laryngeal mask airways from 16% to a massive 86%. Thus, a continued emphasis and continued teaching and again awareness sessions will help us in further improvement and achieving of the targeted pressures recommended by the critical care societies. Thank you so much.
Thank you so much, Dr. Saleem. Now it's the time for question answers by the judges.
Thank you, Huma. That's a nice presentation and a nice poster. So you have definitely addressed an important area when you were working on anesthesia department in the theaters. So you have mentioned about society the guidelines of the society against which we have compared it. My question is, what particular model of education you guys have employed to disseminate your information and to educate your colleagues?
Well, we actually tried to do it by using posters. So these helped in visual aids, and these were displayed in the OR and were actually given handouts to the to the anesthesia technicians, which helped us through the conduct of anesthesia. Then we organized virtual meetings with the anesthesia residents, including the anesthesia consultants and the anesthesia technician team. The technician team was further trained to help us with the use of manometer device to actually change the practice from the minimal audible leak to now shifting on to the manometric measurement of the cuff pressure for the airway devices. So we actually changed our practice, shifting from the objective to a more objective measure of the airway pressures rather than just the subjectivity. Especially with the COVID era, minimal leak testing and minimal occlusive leak is not routinely used now, so we use manometers. So that has helped us a lot in achieving the target pressures again.
Right. And your poster is showing a very simple conveying graphs, which everyone can understand easily. So though the LMA numbers are really small in the second loop,
yeah,
but it looks like there is a big positive stride for LMA as compared to endotracheal tube. Any particular reasons for these numbers, as because you have
initially, initially there have been different methods employed, so there was no uniformity of method to know what exact cuff inflation limits we can use. But after the educational sessions, we actually decided on a single method, which is manometric, which helped us in determining the exact airway device cuff pressures. Moreover, initially in the first audit, we found that the LMA devices were being inflated as per the manufacturer guidelines, which suggested airway.
Time check, please.
So it was about the pressures recommended by the manufacturer. So they were exceeding the limit set by the Intensive Care Society. So we actually stuck to the standard rather than the manufacturer standard the second time of the audit.
Over to you, Mehwish, I think.
Thank you so much, Dr. Huma and Dr. Waqas. Moving on to the next poster by Dr. Saeed Farooq. Over to you.
Is Dr. Saeed Farooq here?
Yes, I was muted, yes. If you're working in Pakistan, you must be familiar with the directly observed therapy in tuberculosis. And the concept is very simple, that every tablet a person takes for tuberculosis, it must be directly observed, because the partial compliance in tuberculosis is more dangerous than no compliance. And when I was working in Peshawar with colleagues with the Chest Society, I put a very simple question: who needs direct observation? People with schizophrenia or people with tuberculosis? And from there, my journey started. I started translating the whole concept of dots into what I have developed as STOPS, Supervised Treatment in Outpatients for Schizophrenia, because the poor compliance is the biggest enemy of physician or psychiatrist in clinical practice. So we used two-steps procedure. And first, we have conducted the focus groups discussions, first to elicit the views of the community participants, patients, and the health workers about changing the dots to the stops, because concept looks simple, but translation into clinical practice is very difficult. And the other thing is that in tuberculosis control program, there already is a tuberculosis control program. The concept of changing the stops, where we will practice it. So we combined the two. First is converting the concept, and second, finding a place to implement it. So in the first part, we conducted focus groups discussion with total number of participants of 26, which helped us to elicit the people's view, participants' views about about supervising the therapy. We came to know about the lay concepts with people have schizophrenia, the concepts about supervision, the barriers about the supervision, barriers in taking the medication, and also the importance of the traditional healers and the spiritual healers in the treatment, and what are the barriers in implementing the program in the primary care. So based on these findings from the focus groups and the qualitative studies which we have analyzed, and I've just submitted the paper now, we are now conducting what I believe is the largest randomized controlled trial in schizophrenia in developing countries. And we have a cluster randomized controlled trial which is evaluating the STOPS intervention into STOPS intervention versus the treatment as usual. We have cluster randomized 24 primary healthcare centers in Peshawar, and we have a target of
3 minutes time check, please.
Okay.
Moving on to the question answer session.
Thank you very much, Professor Saeed Farooq. A good work, and I was pleased to know that it is the UK-based team which has brought this project to Pakistan, and that's a good way of getting the quality going in the right direction. So, am I right to say that you got the grant from Research
Medical Research Council UK, yes.
From UK. What methods did you use to engage the parties on ground in Pakistan? Because sometimes we do find it difficult from UK to engage people in Pakistan.
Thank you. As I mentioned, my work is based in Peshawar, where I have worked about 10 years. I first trained in UK, went back to Pakistan, established a psychiatry department over there. So I have been working with the all the partners over there with the TB control program before I actually applied for the grant. And that was our strongest point when we submitted the grant application, that I had already engaged the stakeholders for the whole program.
Thank you very much. Because this is going to be mainly a qualitative study, so what methods exactly you are going to use to assess your outcomes? If you could detail them, please.
Yeah, the first part is the qualitative. We use the thematic analysis for analyzing the findings from the qualitative, from the focus groups discussion. That has now been done, and that has now been translated into STOPS. The intervention is ready and is now being tested in the randomized controlled trial.
Thank you very much.
Thank you, Dr. Saeed Farooq and Dr. Mohammed Tufail. Now, moving on to our next poster by Dr. Hina Jawaid. Over to you.
Right. Bismillah ar-Rahman ar-Rahim. Assalamu alaikum all. Thank you for giving me an opportunity to present my work. My topic is how I will be discussing how the inclusion of family physicians in the telemedicine center at the University of Health Sciences had an influence on the teleconsultations provided by the junior doctors who were volunteering at the telemedicine center. It all began in March this year when the first wave of COVID-19 arrived, and due to social distancing and lockdown situation, people couldn't reach their doctors and the different healthcare facilities. The government decided to establish a telemedicine center at the University of Health Sciences, Lahore. The Department of Family Medicine was involved in developing an online course for COVID-19 to train the doctors when they would volunteer in and provide services to the community through different resources available for audio and video consultations. Approximately 40,000 doctors registered for the online course, which included things like the COVID-19 pathophysiology, clinical features, how it can be managed, and the website was constantly updated based on the guidelines provided by the ministry's website. In addition, about 480 doctors registered to provide services at the center, and a few weeks down the line, we conducted a short survey and called the patients and see how we were performing. And when we did that, we found out that with regards to the COVID-19 management, there was a huge number of patients who responded to saying that they were satisfied. However, when it came to non-COVID related illnesses, we saw some dissatisfaction from the population on things like how to treat Salmonella typhi, chronic allergic rhinitis, various dermatology, skin condition, and pediatric cases and gynae, and so on and so forth. And this led us to a reform in the way we were providing the services, and we included trained family physicians as the supervising physicians for the 8-hour shift. There were 3 shifts in the 24-hour period of that telemedicine center. When I say trained family physician, I mean physicians who are not only providing services in the community as clinicians, but also have completed a postgraduate qualification in the subject of family medicine. When we did that, we started seeing some change. Another follow-up survey was conducted a few weeks down the line again, in which 200 patients' feedback was taken. And the results showed a significant improvement in the outcome of patient satisfaction compared to the survey that was carried out before. The trained family physicians who were working in the telemedicine center was a completely voluntary service, and I'm thankful to them because they provided the services out of their busy schedule, and some of them used to finish the clinics and then come to work with us.
Move on to question answers.
Thank you.
Thank you very much, Hina. That's a very interesting topic, very, very topical as well. Just a couple of questions on your presentation. I think the first question is, how would you describe your study? Would it be a qualitative type study or would it be quantitative?
Well, it would be quantitative because we have quantified the response of patients, and we also took a feedback from the volunteer doctors and the supervising physicians as well. And we had some really amazing responses from the junior doctors. They said that we've got percentages, I've described them on my poster, the advantages of telemedicine. In a way, because they were supervised, they said their communication, consultation, counseling skills, history taking skills, safety netting improved. They know when their limit finishes and the specialist domain begins. So we've got some figures.
So did you have the baseline data before you started the service, and then you had an intervention, and then whether there was any change from the baseline?
Yes, when we first conducted, we started the telemedicine was inaugurated on the 18th of March. We conducted the first survey on 29th April through to 29 March through to 1st April, so 4 days. And we randomly picked up the patients, and they covered 3 provinces, and there were about 9 cities. So there were about 30 patients who responded. And then we figured out that, yes, in terms of COVID, we are doing fine. But when a patient picks up the phone and calls us for a non-COVID related illness, there is something missing, and we hence need to do something about it. Yes.
Thank you.
Thank you, Hina. Moving on to the next poster by Dr. Muhammad Ayub.
Good morning, everyone. I'm describing a project that's funded by National Institute of Mental Health, US. It's a genetic study, observational study primarily, comparing cases and controls for genome-wide association. We were funded in 2017, and we started the project with fulfilling all the regulatory requirement in 2018. Until now, we have collected more than 10,000 participants. Instead of going into methodology details, which are in the poster, I would just describe some challenges that we faced when we started to implement this project. And there were challenges at 3 different levels. There were challenges of transfer of fund and having all the ethics arrangements through NIMH and the lead institution in US and Pakistani institutions. So that was first one. Then there were regulatory controls from Pakistani government navigating those. And they got more stringent after a year into the project because of some of FATF regulations that government implemented. And the third challenge was collaborating with 22 centers across the country and kind of managing all the political issues that we came across. I think we learned a lot on job, and I think it has been a very successful project. Just highlight of our very initial findings. We compared the self-reported physical health problems between cases and controls. And opposite to what's expected, there were more problems among controls that were defined, but undefined problems were more among cases. So we believe that the physical health is not well monitored, and physical health issues are not well treated in this population. Also, as expected, BMI was high in cases and smoking rate was high in cases.
3 minutes time check, time for question answers. Thank you.
Thank you very much, Dr. Ayub. A very interesting study. So I think that my question is, you mentioned that study was case control, and you also mentioned there's some problems with the controls group as well. How did you select the controls for the cases, and what was the ratio between controls and the cases?
So ratio is 1-to-1, that's the aim, 10,000 cases and 10,000 controls. And because it's primarily a genetic study, so we have cases from different institutions or private sector clinics, and the controls are from comparable population. So our primary objective is to have similar ethnic and gender matched controls. That's the main objective. So
okay,
thank you
very much. I think that's fine. Shall I move on to my next question, which is very relevant?
Yeah.
You talked about your the challenges for different stakeholders. How did you estimate those challenges? What is the rationale? How did you come to the conclusion that these were the challenges?
Okay, so that's, I'm not describing the results, it's more the process that the challenges we faced while we, for example, with the regulations through FATF, we had to stop the project and provide additional paperwork, and we are being monitored by 22 different government agencies. So challenges in that sense. We didn't have any metrics to measure those challenges. Sorry?
How did you measure those challenges? How did you measure those challenges?
We didn't have any metrics to, because that was not the primary purpose of the study. Those are the challenges that we came across, but we didn't have any metrics to measure those challenges. It's
2 minutes time check. Moving on to the next presenter.
Thank you.
So thank you both. So our next presenter is Dr. Ahmed Bilal Akhtar.
Thank you very much, ma'am. Assalamu alaikum. My name is Ahmed Bilal Akhtar, and I'm 4th year resident in Shaukat Khanum Hospital. What I'm going to talk about today is the use of intranasal dexmedetomidine as sedative and alternative to general anesthesia in pediatric non-invasive diagnostic procedures. So approximately 220,000 children worldwide are diagnosed with cancer every year. Similarly, around 8,000 new cases are reported in Pakistan each year. Ladies and gentlemen, the hospital experience itself is quite traumatizing for the children, and one of the precipitating factors is the repeated exposure to general anesthesia, which can be distressing for the children, parents, and caregivers. In addition to that, literature also suggests that prolonged exposure to general anesthesia can have detrimental effects on the development of brain in children along with learning disabilities. Therefore, what we saw was that it will not be wrong to say anesthesia selection can influence the prognosis of cancer. So the study that we did was we assessed the successful completion of pediatric non-invasive diagnostic procedures outside operating room using intranasal dexmedetomidine only. 79 patients were given intranasal dexmedetomidine at a dose of 4 mics per kg, and the results that we had was significant. We had a success rate of 95% with a p-value of less than 0.001. And when we look at the side effects, only 3 patients had arrhythmias, 4 patients developed hypotension, and 6 patients went into bradycardia. All of the side effects were self-relieving with no intervention required. And if we compare the results with general anesthesia, it shows that intranasal dexmedetomidine had a PECU discharge time of 17 minutes less, and the cost was half with dexmedetomidine. Therefore, it will not be wrong to say that intranasal dexmedetomidine, by using intranasal dexmedetomidine, we saw increased parent satisfaction, fewer side effects, reduced PECU discharge time, and last but not the least, we saved 6,000 Pak rupees per patient, making a total of 450,000 Pak rupees for our study. And if we estimate these projections, our hospital could save up to 4.6 million per year. And if this technique is implemented worldwide, we could be talking about saving millions.
3 minutes time check, time for question answers.
Sure.
Thank you, Dr. Ahmed Bilal Akhtar. That's a really nice study. Just 2 quick questions. First one was in terms of how did you measure success clinically? I know there's patient satisfaction and cost effectiveness, but what was the clinical markers of success?
The success was defined as the completion of the procedure without requiring any additional sedatives or conversion to general anesthesia.
And as you showed, your results have shown all the limited data, but really very good results. So how would you convert it into like a large scale change management, if I put it that way?
Yes. So what we have done is that we have started using dexmedetomidine for the radiological procedures in our hospital, which include MRIs, CT scans. We have renograms done here, PET CT scans as well of small children. So we have started using this, and then we can look into retrospectively as well as prospectively. We are planning for a randomized control trial as well to see that how it is as compared to other sedatives.
Thank you. Thanks.
Thank you. Any other questions?
Thank you.
Thank you.
Thank you, Dr. Ahmed. So moving on to our next presenter, Dr. Khalid Abdul Basit. Over to you.
Hello, everyone. My name is Khalid, and I'm one of the population health students at UCL. Today, my topic is the risk assessment score for diabetes in Pakistani population. It's a validated score. It was made in 2012 by Abid in collaboration with University of Oslo. We know that diabetes is an epidemic. Every 1 in 4 above the age of 20 is diabetic. And this is noted in National Diabetic Survey of 2016-2017. 43% of these are undiagnosed as per the IDF. And so this validated score, which was developed in 2012, was validated on 2 different data sets at that time in Sindh. And this time, we validated this on the National Epidemiological Survey across the whole 4 provinces and the federal government with Islamabad. We included more than 4,900 participants, and we concluded that the sensitivity of the score is about 50% and the specificity of more than 70%. Why we think this rapid score is important? Because it does not need any biochemical testing. Every layperson can do its own. So if you have your parameters like age, waist circumference, and the family history, you can stratify yourself if you are at risk of developing diabetes, or might be you are being diabetic, but you're not sure if you have diabetes. So why is needed? So that we can do the mass screening at population level. We cannot test everybody in the whole population for diabetes with limited resources. This score can stratify the high-risk group, and the high-risk group could be investigated further and could be treated earlier. And this is important to prevent the complication of diabetes and to treat the diabetes early as possible so that the survival time could be increased. So in conclusion, how this only could be possible? This could only be possible if the government bodies come together, if the telecommunication bodies come together, which they have now, and the social media and print media disseminate this score across the whole population, so risk stratification could have been possible and the people could have been saved much more earlier through primary prevention, by reducing the risk, by modification of the lifestyle, or treating early if they have already developed diabetes. Thank you very much.
Thank you, Dr. Khalid. Moving on to the question answers.
Yeah, so can you hear me?
Yes.
Yeah, so I'm just a couple of questions I had. One was that, what was your role in this study? Were you the one who kind of helped with the study, or have you just picked on this study from Pakistan, or what is your role here?
So because this was conducted in 2016 and 2017, the National Diabetic Survey, and I was doing as a research fellow at that time and Abid afterwards. So I did this rapid score validation on that data set.
Okay, fine. I see. I understand now, because I wasn't very clear how you were contributing to it. So that's fine.
No problem.
Yeah, okay. So because this wasn't part of the study, I know that it wasn't part of the study. It was a secondary subset of parameters that was done after the study was completed. So it's kind of retrospective, isn't it? But my question is that, you know, there are already validated scores. And I think that rather than scoring people, because it is usually how what we rely on is that if both your parents have diabetes, then your risk is 40%. If one of them has it, well, you have 60%. If one of them has it, you've got to 40%. So wouldn't you think that a BMI and a family history would be enough rather than going into anything else, or, you know, going into kind of lengthy logistics?
Okay. So if you see the parameters which we have used here is age, central obesity, and the family history. Yeah. And we know that central obesity is more sensitive than BMI for consideration of insulin resistance, because abdominal obesity causes more insulin resistance. Secondly, the question which you raised first was why the other risk score could not be used. And the reason is, we know that there is Finnish risk score, there is Canadian score, there's Australian score, and many more for diabetes, but they are all done in the Caucasian population. And the risk stratification could not be compared with the population differences. One, because of the change in the ethnicity. Second, because we are more prone to develop diabetes because of the genetic component.
2 minutes time check.
Okay, so another question that I wanted to ask you, you know that, yes, we are genetically more predisposed and there is more central obesity.
2 minutes time check, time for the next presentation.
Have I got 2 minutes or not?
Your time is finished.
Time is finished.
Just let Dr. Tabinda ask one more question. It's just relevant to that. Yeah.
Okay. I just wanted to ask you this, that when we have got a lower BMI anyway, and I know that that's why you needed the scoring, the new scoring, but we have got central obesity anyway. We have got a lower BMI, normal BMI than others. So I couldn't quite understand why we needed a new score.
Okay.
Yeah.
So basically, as you know, the WHO says we have got.
Sorry, I just also wanted to say that has got a very low sensitivity. It has got 47% sensitivity. So, you know, you're kind of missing out on so many people, false negatives.
Yes, that's absolutely true. But as I said earlier, is a screening tool, and it's only to stratify the high risk people. And we know, as per the IDF 2019, that we have got 8.5 million people undiagnosed. So if the sensitivity is about 50%, we can still get a screening of more than 4 million through this score.
Okay.
And
thank you. Thank you. Thank you. We can move on. Thank you. Thank you very much. Thank you.
Thank you, Paul. So the next presentation is by Dr. Shafqat Rasool. Over to you.
Yeah, thank you, madam, for giving me this opportunity. I'm Dr. Shafqat Rasool, and I'm working as Assistant Professor of Gastroenterology and Hepatology at PGMI Lahore General Hospital, Lahore. I'm going to present this this pilot project for hepatitis microelimination in one of the districts in Punjab, which was formulated to shape of our future response toward HCV elimination. Actually, Pakistan has highest burden of hepatitis C in world after China, and has highest prevalence after Egypt, and there are about 8 to 11 million individuals with active HCV viremia and 250 million new infections per year. And Punjab formulated about 50 to 70% of these cases. And a recent survey by Punjab Bureau of Statistics showed an increase in the prevalence in Punjab for HCV from 6.7% to 8.9%. That is quite alarming. WHO has a target for HCV elimination by 2030, but despite we have a strong network for hepatitis clinics in 138 DHQ and THQs and 17 in teaching hospitals, still we are lagging behind for the number of HCV patients that need to be tested and treated. In last 2 years, we were able to treat only 5% of the HCV infected patients, and most of the patients remained undiagnosed. And this current trajectory of HCV response towards HCV elimination, that is mainly based on cell referral, we will not be able to eradicate HCV by 2030. So we need a general population-based screening that is recommended by WHO 2017 guidelines on testing. So this microelimination project was conceived after reviewing the successful Egyptian model of HCV elimination in 73 villages. This is a collaborative project where the WHO provided a technical support, and the other help, mainly it was a project of Government of Punjab and both health departments. And in this project, 4-pronged approach of test and treat strategy was used. The initial pre-testing phase that lasted for 3 weeks from 28 October to 21st of November 2019. And in this, we arranged almost 45 education sessions in 45 education sessions in different schools and in Union Council. And seminars were also conducted at the community level, and handouts, information and education material were disseminated. After initial screening at village and PHU and Union Council level, the positive cases were linked to the care, and all negative cases were provided the first dose of hepatitis B vaccination there and then. And
3 minutes time check, time for question answers.
Thank you. I think that was a really good study. So I think I just wanted to ask you 1 or 2 questions. One was around when did this project start? And then I think I just want to understand, have these findings been presented anywhere else as well? So this project started in after 28th of July, when Prime Minister hepatitis central in federal project was conceived, and then this project was conceived in Punjab with the technical support of WHO, and this project is not presented anywhere. Okay, thank you. And I think that's my second question was in terms of the people who who were visited in the Panwa Council, did they then travel back to LGH to have their samples taken and tests done?
Sorry, I didn't get your question.
The target population who had, where were the actual blood samples taken for tests?
Yes. The blood samples after initial screening, those turned out to be positive. The samples were taken there and then at the Union Council level, and then the sanctification and the initial steps were taken at the Tehsil level and were sent to the Lahore in the central lab where all the testing were done. And after having these results were dispatched back to the concerned Union Council, and those turned out to be positive with PCR, were offered treatment in the Union Council.
Okay, thank you. And what was the compliance rate in the people who were tested in terms of them getting the full course of treatment?
Yes, if you see we actually covered more than 95% of the patient that turned out to be positive. We are approaching rest of the people, and
2 minutes time check. Time for the next presentation. So our next presenter, thank you so much. So next presenter is Dr. Atif Munir.
Thank you very much. Mehwish, am I audible?
Yes, you are.
Okay, thank you very much. So I was in UK for a decade. I was trained there and I returned back home about 4.5 years ago. The three of the primary aims that I returned, one of them was to help and assist the underprivileged population of Pakistan in my capacity. Keeping that in mind, I established this multidisciplinary diabetes clinic at my parent institution, which is Fatma-e-Murrey Hospital. We all know the diabetes prevalence in Pakistan is around 20%, and that's a big number. We are the 5th most populous country around the globe, and to date, we have 75 registered diabetologists across the country. So we can well imagine the access to endocrinologists by diabetes population. We also know that 24.3% of our population lives well below the national poverty line. So it's a huge number of people who can't afford good care or access to endocrinology or endocrinologists across the countries. So I established this clinic about 3 years ago at Fatma-e-Murrey Hospital for the underprivileged. My team of people who review each and every person walking through this clinic consists of myself as the endocrinologist. We have a dedicated nutritionist. We do the foot check for complications screening, like to look for retinopathy, for neuropathy, etc. for every patient at least once a year, and a retinal screening for every patient who walks through the clinic at least once a year, depending on the findings. All of these services are provided on as a one-stop clinic on a OPD card or outpatient department card, which just costs the patient ₹100, and that's about it. We are a trust hospital, so we do not offer any free medications or any free lab testing. So that is to be kept in mind when we assess the numbers. The aim of the clinic was to improve diabetes care by allowing people to have access who otherwise can't afford access to a trained endocrinologist. We are screening them for complications to pick them early, as we want to make sure that we prevent morbidity and mortality associated with this condition that is increasing in numbers by leaps and bounds as days goes on. Having established the clinic about 3 years ago, and keeping in mind that this clinic just runs once a week, it is a one day a week clinic, which just lasts 4 hours. Alhamdulillah, to date, we have reviewed about 6,000 patients in this clinic. And for this clinic, I was one of the finalists for the Royal College of Physicians prestigious Excellence in Patient Care Award in the international category. And I was one of the 4 people who were shortlisted just this year across the globe for this award. Looking forward, the way I want to see this clinic going into time in the next year or the year after, we are also in the process
3
of
minutes time check, time for question answers.
Okay, thank you.
So well done, Atif, for taking this initiative. You always do. I just had a couple of questions. I know it's only been 3 years, but have you had any outcomes from this clinic, i.e. have you managed to save amputations? Have you managed to save sight, which would be the main objective? And my second question is that, you know, because you can only X number of patients per week. And I remember my time in Mayo Hospital where we used to have hundreds in diabetes clinic every day, and we were still not able to, you know, come up to expectations of all the patients that were there. Do you have any plans of rolling it out to the community, which would be the, you know, future forward really, would be training up people in the community and rolling it out rather than, you know, containing it in your hospital only?
So just to answer the number question, we've, because we're not a public sector hospital, so we have all the liberty to cap our numbers. I know it's a once a week clinic, we've capped our numbers to 50. The numbers were jumping up to more than 50 per clinic. So I've had to cap the numbers because that is my control, because we don't want quality to be compromised. As far as we can't compare it to any public sector hospital because A, you can't have control over any numbers. B, we don't give any free medications as you do in public sector hospitals. We don't provide any free lab tests. So as far as the numbers is concerned, that's all in my control. The other thing is, yes, I would love to roll it out, but I would need a lot of support, I would say, from the government level to roll out such clinics out in the community, but all for it. As far as trainees expertise is concerned, we are now a recognized center for training people in endocrinology, and we are training people there who would, on our behalf, go out and perhaps establish similar services out in the community.
So anything on, you know, the benefit to the patients? Did you?
Yeah, as far as the benefit is concerned, yes, we have benefited out of it. For the benefit is in terms of from my experience, but because it's a new clinic still in its infancy, the next step is to quantify that benefit and get it out and published in the form of data, which we're starting to work on.
Thank you. Thank you. I think we're up for time. Yeah, thanks. Thank you, Atif. Thank you. Thank you.
Atif, just a quick question. You mentioned there are 75 endocrinologists and 24% below national poverty line. I'm sure it's not true.
The 24.3% below poverty line is the general population, not the endocrinologists.
Yeah, thank you. So I was just making comments. Thank you. Good study.
Okay. Should we move on to the last talk? Mehwish, would you introduce the presenters?
So the next talk is by Dr. Rumana Durrani. Over to you.
Thank you very much. Good afternoon, everyone. I'm Dr. Rumana Durrani, consultant pain medicine at Shaukat Khanum Memorial Cancer Hospital and Research Center. I'm presenting the new normal pain medicine. The COVID-19 outbreak has led to rapid changes throughout the healthcare system. All the medical services were ceased except emergencies, and the resources were mobilized to combat the fight against COVID. The pain clinic and interventions were also ceased following the global changes. COVID seized the services, but not the diseases. The treatment has to continue as the disease continues. Many of our cancer patients were on regular opioid, which are not available outside our hospital. To reach out the patient, we looked for alternatives. Telemedicine is the use of technologies and telecommunication system to administer healthcare to the patient who are geographically far from the physician. We began with e-visit, that is, patients on follow-up list were contacted on telephone to refill their opioid and informed them to send one person to the hospital pharmacy to pick up the drugs. Later, the hospital provided us with the smartphones in OPDs, and we officially moved on to video visits on WhatsApp. This gave us the opportunity to see the condition of the patient and also check that they are using the proper drugs. Despite problems of unfamiliarity of technology for the patients and for the physician, and the unavailability of the internet, we did well, as is depicted in the graph. So the graph A shows the trends of the clinic patients last year and comparison of this year. Of note, we had 3 sessions of clinic per year before COVID, which was reduced to 2 sessions per week. We started teleclinic in April, and it still continues. After the emergence of ASRA and ISRA guidelines, physical clinics were resumed as well in our hospital. Currently, we are running teleclinic and physical clinic side by side. We are doing 1.5 session of physical and 1.5 session of teleclinic. The trends in graph B are quite comparable to previous year's trends, and we are now catching up on the number of the previous year. With all the technical difficulties, we are in need to improve the services without compromising the safety. This is the only way to ease the burden of this pandemic on all of us and to embrace the new normal. Thank you very much.
Thank you, Dr. Romana. Time for question answers, please.
Yeah, thank you, Romana. It's a nice presentation, and being an oncologist, pain management is quite important for us. You guys are doing a good job. So have you collected any data on patient satisfaction when you're using this new normal thing?
No, we haven't yet collected any data, but because it's a narrative of the establishment of a pain clinic, we do plan to make it as a study and find out the satisfaction rate as well.
And what is the actual gain you expect in future by measuring this particular activity, and how these numbers support that gain?
Obviously, it is for the betterment of the patients and to provide the facilities wherever they are.
Right. Any challenges or any?
Yes. In the beginning, it was quite challenging because familiarity with the technology was the main issue between physicians and the patients. At times, it became really difficult to talk. It was a very tiring clinic. To be honest, I don't get tired in the physical clinic, but it is very tiring to do a teleclinic. So to make them understand the way they hold their phones and they are showing, they're not showing their face, they're showing something else to you, and you're asking them, point out where the pain is, all these type of things. Or maybe sometimes there is light is coming right into the camera and you cannot see them. So these type of technical issues were quite a lot in the beginning, but for the chronic patients, they learned it quite quickly. And we also moved on to the telephonic conversation as well. At times, there was unavailability of the internet, so it was not possible to communicate with them.
It's a new learning curve, not only for the medical professionals, but the patients, obviously. So did anybody else in the in the hospital or the trust get benefit out of your data to roll it out to the other departments?
Yes, the teleclinic was started by all the other departments. As I said, that the smartphones were provided to us. So the teleclinic was not only in the pain medicine, but all the other departments also started doing it.
And they're using the same software and the technology?
Of course, yes. The poster actually have the photograph of a surgeon.
All right. That I didn't realize. No disrespect to the surgeons. Thank you very much.
Thank you.
Anybody else who wants to ask anything?
I think we are running short of time. Mehwish, can you wind up and then we can conclude the session?
Thank you everyone for being a part of this session, and to all the presenters for such good posters. Full posters are available on the symposium website, and you all can join now the plenary session by clicking on the channel 1 link on the symposium website. Enjoy the rest of your webinar.
Okay, thank you very much, Mehwish. We are really very thankful to you for hosting this session. I'm extremely grateful to all the presenters and especially the judges for giving them their time and exploring this, these posters. So the results would be published by the end of this symposium as per the program mentioned on the symposium website.